If you recently had your blood drawn and your vitamin B12 test came back sitting somewhere between 200 and 450, your doctor almost certainly smiled, handed you the paper, and told you everything was perfectly normal. And that specific number, and the medical assumption that blindly goes along with it, is arguably one of the most dangerously misleading lab values in all of routine senior medicine. Here is the terrifying reality. Up to 30% of adults over the age of 60 who are actively suffering from profound, clinically meaningful B12 deficiency, meaning the delicate protective coating on their nerves is physically disintegrating, their cognition is heavily clouding, and their physical balance is severely degrading, possess a completely normal serum B12 level on a standard basic blood test. The biological deficiency is absolute reality. The nerve damage is undeniably real, but the cheap standard test your doctor is using to look for the problem is utterly failing to find it. There is an advanced test that actually finds the hidden damage. It costs roughly $30. It uses the exact same vial of blood you already gave them, and it is almost never ordered during a standard primary care visit. It involves two specific markers, methylmalonic acid and homocysteine. Those two tests reveal the critical biological truth that a standard B12 test cannot. They tell you if your cells are actually capable of using the B12 floating in your blood. I am Dr. Marcus Okoro. On this channel, we strip away the medical jargon and dive directly into the published research on the medical decisions that dictate your survival after the age of 65. Today, we are going to look under the microscope at exactly why the standard B12 test misses massive amounts of nerve damage. We will expose the 4 incredibly common prescription medications that are quietly paralyzing your body's ability to absorb B12, outline the 3 specific tests you must demand at your next physical, and reveal the exact active form of treatment required when your nerves are already severely damaged. To understand why the standard blood test completely fails you, you must understand a profound piece of human biochemistry that takes exactly 30 seconds to explain. Vitamin B12 floats through your bloodstream in 2 entirely different forms. The first form is B12 tightly bound to transport proteins called haptocorin and transcobalamin. Roughly 80% of the total B12 in your blood at any given second is sitting uselessly on these proteins. It is physically there. The cheap laboratory test detects it. It aggressively pumps up your total serum B12 number on your lab report. But here's the biological catch. Only the tiny fraction of B12 that is bound to one highly specific transporter, transcobalamin 2, can actually be delivered inside your cells to do its vital job. That tiny fraction is called active B12, and it is the absolute only fraction that matters for your survival. In millions of older adults, that active, life-saving fraction is dangerously low, completely starving their brain cells, while their total B12 number looks beautifully falsely reassuring. This is exactly why methylmalonic acid matters so profoundly. Methylmalonic acid, or MMA, is a toxic byproduct that your cells physically produce when they do not have enough active B12 to complete their chemical reactions. If your active B12 drops, MMA rapidly accumulates in your blood. The MMA blood test does not measure the B12 floating around. It directly measures the catastrophic cellular consequence of B12 starvation, regardless of what your normal serum number says. The exact same logic applies to homocysteine. It spikes aggressively when B12 is functionally missing. These 2 markers tell you what your cells are actually experiencing, not just what is floating past them. A monumental 2013 review published in the New England Journal of Medicine, one of the absolute foundational papers on this topic, definitively concluded that any patient over the age of 60 presenting with neurological symptoms must have MMA and homocysteine measured, regardless of their standard B12 result. That rigorous medical recommendation has been sitting in the clinical literature for over a decade. Yet, it is still not standard practice in most primary care offices. Let me explain this with a patient. Let us call her Margaret. Margaret is 72 years old, a retired teacher, and generally very healthy. She came to my clinic complaining of slowly worsening, painful tingling in both of her feet over the last 18 months. She experienced occasional, terrifying unsteadiness when she stood up from a chair, and a vague, persistent sense of fuzzy thinking that she had been dismissing as just a normal part of getting older. Her primary care physician had recently checked her B12. The number came back at 285, officially legally normal. Her doctor had highly reassured her. She accepted it. But when I reviewed her chart, 3 massive blazing red flags stood out. First, she had been taking metformin for 7 years to control borderline diabetes. Second, she had been swallowing omeprazole for 15 years to manage acid reflux. And third, she ate a highly plant-leaning diet. not strictly vegan, but significantly lighter on animal protein than the average senior. Every single one of those three factors is an independent, massive B12 absorption risk. When you mathematically stack all three, severe cellular B12 insufficiency is virtually guaranteed. I immediately ordered a methylmalonic acid and a homocysteine test. Her MMA came back at 480, astronomically above the normal upper limit of 270. Her homocysteine was severely elevated. The cellular evidence of profound B12 starvation was absolutely unmistakable, despite the normal number sitting on her standard lab report. We aggressively started her on methylcobalamin, 1,000 micrograms via intramuscular injection, twice a week for the first month, tapering down to weekly. Within just 5 weeks, the agonizing tingling in her feet had vanished by 60%. By week 12, her physical unsteadiness was completely gone, and that fuzzy thinking she blamed on aging, utterly resolved. The nerve damage that was biologically reversible was successfully reversed. But the terrifying truth I need you to hear is this. Margaret had been quietly, permanently losing critical nerve function for years, fully operating under the false assumption that her B12 was perfectly fine. Why? Because her doctor used the wrong test to look for the fire. Before we move to the medication list, I must flag the single most catastrophic, under-discussed B12 risk for older patients. It is the simultaneous combination of metformin and a proton pump inhibitor. Drugs like Prilosec, Nexium, or Prevacid. Both of these drugs are prescribed like candy after the age of 60. Both independently destroy your ability to absorb B12. When you take them together, the destructive effect is multiplicative, not additive. If you have been on both of these drugs for over a year, and you feel even the slightest tingling in your toes, you absolutely must demand an MMA test, not just a serum B12 test. Here are the 4 specific medications and biological conditions that most aggressively paralyze B12 absorption in older adults. Risk number 1, metformin. This is the single most widely prescribed diabetes medication on the planet. A massive 2016 study published in the Journal of Clinical Endocrinology and Metabolism definitively proved that long-term metformin use, defined as over 4 years, increases your clinical risk of severe B12 deficiency by a staggering 30%. The mechanism is highly specific. Metformin physically interferes with the calcium-dependent absorption of B12 in the very end of your small intestine. The medical literature is absolutely clear. Every single patient taking metformin for over a year must have annual B12 testing that explicitly includes MMA. Almost no primary care clinic actually executes this protocol. Risk number 2, proton pump inhibitors. We are talking about omeprazole, esomeprazole, and lansoprazole. These highly potent drugs chemically reduce your stomach acid by 90% or more. A landmark 2013 JAMA study demonstrated that utilizing a PPI for over 2 years is associated with a massive 65% increased risk of B12 deficiency. The biological reason is undeniable. Your body absolutely requires harsh stomach acid to physically break down the proteins in your meat and eggs and release the B12 trapped inside. Without that acid, the life-saving B12 simply passes entirely through your digestive tract and out of your body without ever being absorbed. Risk number 3, long-term nitrous oxide exposure. Nitrous oxide, commonly used as laughing gas during extensive dental procedures, directly and violently inactivates B12 in your body by oxidizing the crucial cobalt atom sitting at the center of the vitamin. A single isolated exposure is rarely catastrophic, but repeated, heavy exposures are. If you have endured multiple extensive dental procedures utilizing nitrous oxide over the past few years, you must explicitly mention this during any neurological workup. Risk number 4, atrophic gastritis. This is not a pharmaceutical drug. This is the reality of aging. Roughly 15% of all adults over the age of 70 develop age-related atrophic gastritis. The parietal cells inside your stomach naturally begin to fail, the production of intrinsic factor plummets, and your biological ability to absorb B12 crashes. This is a normal, age-related mechanical failure, not a disease. But it is the exact reason why the threshold for aggressive B12 testing must be radically lowered for older patients, regardless of what medications they are taking. I have designed a highly specific 3-step diagnostic protocol that you must request at your next physical. Test 1, serum B12. This is the standard cheap test most doctors reflexively order. It is absolutely not useless. It is simply a starting point. The conventional lab normal range is usually 200 to 900. But the biologically meaningful threshold for older adults is vastly higher. Highly trained functional neurologists consider any level under 450 to be deeply suspect in any patient over 60 displaying neurological symptoms. Test 2. Methylmalonic acid, MMA. This is the exact test most doctors completely skip. The normal range is strictly under 270. If your MMA is highly elevated while your standard serum B12 looks normal, you have definitively proven functional B12 starvation. It is absolutely worth the extra $30 out of pocket. Test 3. Homocysteine. The normal range is strictly under 15. Severely elevated homocysteine paired with a normal B12 is yet another blaring siren of functional deficiency, and it is massively, independently associated with rapid cardiovascular and cognitive decline in seniors. The combination of these three tests provides a flawless, unassailable medical picture. If you have any peripheral nerve symptoms, tingling, numbness, a burning sensation in your feet, or unexplained balance issues, and your doctor only ran a basic B12 test, you must explicitly demand the MMA and homocysteine add-ons. Now, if you prove that you are deficient, the treatment is critical, and the actual chemical form of the B12 matters vastly more than most patients are ever told. Do not buy cyanocobalamin. This is the absolute cheapest, purely synthetic form of the vitamin, and it is the exact form used in almost all cheap, over-the-counter grocery store supplements. Your body is forced to laboriously convert it into an active form, and this chemical conversion is wildly inefficient, especially in an older adult with a declining metabolism. It is adequate for basic prevention, but it is biologically inferior for treating established active nerve damage. You must demand methylcobalamin. This is the fully active, highly bioavailable form of the vitamin. It is the exact chemical structure most likely to produce rapid, profound neurological improvement when your nerves are already stripped and damaged. It is readily available in oral, sublingual, and injectable forms. For a mild deficiency presenting with zero severe neurological symptoms, a daily sublingual dose of 1 to 2,000 micrograms of methylcobalamin for 3 months, followed by retesting, is a highly reasonable protocol. But for a severe deficiency presenting with active neurological symptoms, like numb feet and failing balance, the absolute gold standard is an intramuscular injection of methylcobalamin or hydroxycobalamin. The standard clinical protocol is typically 1,000 micrograms injected 2 to 3 times a week for the first month, tapering to weekly for the following 2 months. The entire biological reason for the injection is to completely bypass the broken stomach absorption process that caused the starvation in the first place. Once your cellular levels are fully restored, most patients can safely transition to a high-dose oral maintenance protocol, but you must reassess that MMA level at 6 months and annually thereafter. What should you realistically expect from treatment if your nerves are already damaged? The pace of your recovery relies entirely on exactly how long the damage has been silently accumulating. Searing, tingling, and numbness that began within the last 12 months often improve spectacularly within 4 to 8 weeks of aggressive, active replacement. Severe balance issues follow a very similar timeline. Deep cognitive fog can take several months to fully clear and stabilize. However, structural nerve damage that has been silently compounding for 5 or more years may never fully reverse. The protective myelin sheaths can biologically repair themselves to a certain degree, but if deep axonal damage has occurred, that specific loss is typically permanent. This is exactly why early, accurate testing is a matter of profound urgency. A deficiency caught at 6 months is miraculously recoverable. The exact same deficiency caught at 6 years is a permanent tragedy. Margaret sent me a video on her phone last month. She is standing perfectly still on one leg in her kitchen, with her eyes completely closed, and she holds the flawless position for over 30 seconds. She attached a note that said, "Dr. Okoro, I would have gone the rest of my natural life blindly believing that the agonizing tingling in my feet was just getting old. Thank you for ordering the right test." That is the absolute reality I want you to walk away with today. The specific test that actually finds B12 deficiency in an older adult is rarely the cheap one your doctor clicks by default. Demanding the correct test is the only conversation that matters. If you have any tingling, numbness, unexplained balance failure, or cognitive fog, and you are currently taking metformin, swallowing daily acid reducers, or are simply over the age of 70, you must explicitly demand a serum B12, a methylmalonic acid, and a homocysteine test. All 3. Stand your ground and insist. If this deep dive into neurological biochemistry provided you with value, please hit the subscribe button and tap the notification bell. My commitment is to strip away the clinical confusion and bring you the pure, unvarnished medical truth every single week. Before you leave, drop a comment down below. Tell me, has any doctor ever actually ordered an MMA or homocysteine test for you? I read every single comment, and the diagnostic patterns I see help me build the exact life-saving protocols you need next. Take care of your nerves and take care of your brain. I will see you in the next video.